Good afternoon, everybody. I'm Dr. Pratik Kande, Chairperson for the Amox Endocrinology Committee. A warm welcome to today's event. We have a galaxy of stars from all over the country who are chairpersons as well as speakers for today's event. And we are proud to welcome our office bearers of Amox. Welcome all of you, and we look forward to an exciting afternoon with a lot of key issues in obstetrics and gynecology being discussed. Before we begin the scientific proceedings, as usual, I would like to begin by offering my gratitude to our AMOX President, Dr. Nandita Palchakar. Madam is the current President of AMOX, immediate past President of FOXY, also been a President of IAG and Mobile Society in the past, Vice President of ISAR currently. Thank you so much for being a guiding light and for always promoting and encouraging those students. Thank you, ma'am, for always being there for us. Next slide, please. I would also like to express my gratitude to Dr. Arun Nayak, a distinguished academician and fantastic vaginal surgeon. He's the Secretary of AMOX. Thank you, sir, for supporting us in our academic endeavors. Next slide, please. At this stage, I would like to express my gratitude to the ICOG chairperson, Dr. Uday Thanawala, and the Secretary of ICOG, Dr. Ashok Kumar, for granting us the ICOG credit point for today's event. Thank you so much for your support and your encouragement on this. Next slide, please. Let me take the opportunity to introduce the four fantastic chairpersons who are going to be here to guide us through the scientific proceedings today. First and foremost, we are delighted to welcome Dr. Kiran Kurtakoti, sir. Sir is the Vice President of AMOX. In the past, he's served several different roles in AMOX, including chairperson for the MPP committee, chairperson for medical education, research and training, the second joint secretary of AMOX way back in 2009. And sir has also been the chairperson for the MPP committee of FOXY from the tenure 2009 to 11. He's organized several amazing conferences in a different era when we used to have physical meetings, and we yearn for those days. Hopefully, we'll be able to meet next month at a conference which he's organizing in August in Pune. Thank you so much, sir, for joining us. Next slide, please. We are also delighted to have with us Dr. Sujata Devi. Madam is an honorary clinical associate at the Noruchi Wadia Maternity Hospital and the Jagjeevan Ram Railway Hospital in Mumbai. Also attached to several hospitals in South Mumbai. She is the assistant editor of TOG, which is the official FOXY journal. She's recently been elected the joint clinical secretary of the Mumbai OBGYN Society, and she also serves as the first joint secretary of AMOX. Thank you, ma'am, for joining us. Next slide, please. We have a very distinguished and senior obstetrician and gynecologist, Dr. Bharti Abhyankar. She's a consultant at Purva Hospital in Kolhapur since 50 years. She's the first to start the menopause clinic in Kolhapur way back in 2005. She's done extensive work in cervical cancer detection and prevention. She's been chairperson for the Preventive Oncology Committee of AMOX. She has one of the first FOXY recognized colposcopy training centers at her hospital in Kolhapur. Also served as chairperson for the AMOX conference, the annual conference in 2013. She's organized the West Zone Yuva FOXY in 2009. And she has a regular newspaper column in the Marathi newspaper Lokmat under the heading Hitubuz. We are really delighted to welcome Dr. Bharti Abhyankar. She is currently the zonal coordinator of AMOX and a very busy personality. Thank you so much, ma'am, for joining us. Next slide, please. We are also delighted to have with us Professor Bharti Maheshwari. She has served as the chairperson for the MPP committee of FOXY. She's professor and head of department at Muzaffarnagar Medical College. She has a diploma in IVF and reproductive medicine from Germany. She is also currently a governing council member of ICOG, joint secretary of UPCOG, vice president of the Meerut OBGYN Society, author and editor of many textbooks in OBGYN, published several papers and review articles in Lex journals. Kamini Rao, your FOXY orator, helped to organize the North Zone and UPCOG conferences at organizing secretary. And she's somebody who we all look up to. She has a long way to go and wish her all the very best for her further journey in FOXY. So without further ado, I hand over the scientific proceedings to our chairpersons. We have three fantastic orators today who will be joining us. The first is Dr. Ritu Khanna. Second is Dr. Sanjeeva Reddy. and the third is Dr. MC Patel. But I will hand over to Dr. Kiran Kotakoti sir now to introduce the first speaker of the day, Dr. Ritu Khanna. Over to you, sir. Sir, please unmute yourself.
Sir, request you to unmute, please.
Well, thank you, Dr. Pratik. On behalf of Amox, I would like to welcome all of you on this particular platform of Amox. As you all know, that Amox is Association of Maharashtra Societies of OBGYN. But today we have all the speakers who fortunately are outside Maharashtra. So welcome all of you on the dais of Amox or on the platform of Amox. Today being Guru Purnima, I salute you, pranam you from this dais. All of you have been teaching us and inspiring us in the past so many years by your talks at the national and international forum. So thank you so much. My best wishes to Pratik. Literally, Pratik, you are a guru in a different way because I am following you practically every day, and all of you must see the way Pratik has shaped up in the past, say 1 or 2 years, in the way in which he is handling the seminars and the way in which he is taking care of so many faculties all over India, that it's really it's a thing which must be emulated. And also thank you, Pratik, for all the Facebook quotes that you share. Yeah, for example, yesterday I was reading your quote, your energy introduces you before even you speak. So that is the quote which has gone into my mind, and really hats off to you for bringing us all together on this particular dais. So without much ado, I would request the first speaker to get on with the talk. It's a pleasure for me to introduce a fellow Foxian, Dr. Ritu Khanna. Dr. Ritu is the director of the Khanna Medical Center Fertility Clinic. She is the current chairperson of the Foxy Food and Drug Medical Surgical Equipment Committee. She is the secretary of Society of Fetal Medicine of the UP chapter, VP of the Women's Doctor Wing of IMA, executive member of UP TOG, vice president of the VOGS 2019-20, secretary of the Varanasi Society 2018-19, joint treasurer of the Indian Fertility Society 2018-20, scientific secretary of the IMS Varanasi chapter, the current scientific secretary, organizing secretary of UPCOG 2019, organizing secretary Fertivision 2016. She is working exclusively on single embryo transfer. She is awarded the Best Chapter Award as secretary of the IFS UP chapter, IFS Best Executive Award 2016, Best Paper Award UPCOG 2020. She has published many papers on male and female infertility and published her first study on the role of CoQ in male infertility, and also presented many papers at the national and international fora, that is the ISAR, IFS and AICOG. So Dr. Ritu Khanna, she will be talking on ovarian stimulation the right way, safe ovarian stimulation practices. So please, the dais is yours, Dr. Ritu. Please get on with your talk.
Thank you so much, sir, for the very kind words, and my pranam to all my teachers in some way or the other on this Guru Purnima day. My thanks to Dr. Pratik Tambe, sir, who has always been an inspiration for all of us and inviting me here. And my due regards to the President, Dr. Nandita Palchetkar, Dr. Arun Naik, and my chairpersons, esteemed chairpersons for today, Dr. Bharti Maheshwari, and also Dr. Sujata, and my co-speakers, Dr. Sanjeeva Reddy, sir, and Dr. MC Patel, sir. It's always a pleasure to be on the AMOX platform. And today I come up with my presentation on the safe ovarian stimulation protocols. The rationale for the use of ovarian stimulation is to increase the number of oocytes available for fertilization and thus to improve the chance of pregnancy without compromising the quality of the oocyte. So it depends what's your aim. You may be inducing in cases of anovulatory infertility or doing a superovulation or a controlled ovarian stimulation in an anovulatory or ovulatory cycle. Your objective, whether you want more than one, or you want multiple follicles, but your aim is an ideal outcome. That's a singleton live birth at term, minimize all the complications of cycle cancellation, multiple pregnancy, and OHSS also. If we go into the PCOS endocrinology, there's a difference in the GnRH, the pulsations. We see here this is the normal, and there is an increased frequency of this variation over there. So the efficacy of the androgen precursor conversion is increased. So in response to the raised LH versus FSH, there's increased circulating levels of free testosterone, the endosternadione, the dihydroepiandrosterone, and the DHEAS. So the androgens now in excess do have a stimulatory role in the early follicular growth by augmenting the follicular FSH receptor expression and thereby amplifying the FSH effects. There's X6 the density of preantral follicles compared with the normal ovary. And why does this happen? There is a large cohort of small follicles arrested in development, and they're still capable of responding to the exogenous FSH. There is a greater sensitivity to gonadotrophin stimulation. Therefore, we get a cohort with an explosive follicular development also. So what we find is in these patients, the response is very unpredictable. The dose is not predictable. The number of days, the control over the cycle is difficult, and there may be an excess ovarian response. Fertilization may not be up to the mark. There may be immature oocytes, low implantation, and high miscarriage rate. So what do we need to do in such type of patient? They are challenging. So we need a selection of the patients of PCOS, do a good pre-IVF workup, a pre-IVF treatment, what do I need to put them into, which regime, and challenges in titrating their doses and unpredictable exaggerated responses. Yes, they are prone to a life-threatening condition of ovarian hyperstimulation, maybe a mild in 8 to 23 and a moderate in 1 to 7, and also severe in 0.5 to 1, which we need to really prevent. So we need to identify all the risk factors, and the risk of developing OHS is related to the magnitude of the response that I'm going to get, the exposure of these ovaries, and the use of any GnRH analogs. So when we go into this patient detail, we find that we need to care. She's very young, she's lean, she has a high response in a previous controlled ovarian hyperstimulation. There was a cycle cancellation, and there was a development of a moderate to severe OHSs. When we were stimulating her in the last cycle, we may be having a reports that her E2 was higher up, more than 3,000, maybe 20 follicles, at least 10 millimeter, and retrieval of more than 15. So in the history, or during a previous stimulation, we may get the clues. So now how do we opt this treatment policies from our side? We could do a primary prevention, controlling the FSH exposure, the dose and the duration. You could change your protocols or the GnRH analogs. And if you're going into, you could still manage to prevent her going into complications by reducing the HCG or dopamine, or using an agonist we'll just come across. So the starting dose that we decide will depend upon the age, the BMI, the PCOS, the ovarian reserves, and the previous response. So while we're doing a scan for her on the day 2, we need to really sweep up with the ovaries and look into these antral follicles and sum up the antral follicles by the transvaginal ultrasound and just plan, where does she stand? She is a normal or she is a high-risk responder. Why? Because we have this whole chart in front of us which shows that on the basis of antral follicles, which we can decide what is the response I'm going to get. If she is going to go by my expected, or I need to high dose, or I need to lower my dose on. Studies have also shown that polycystic ovarian morphology has been found to be better discriminatory than the ovarian volume in these patients, because they have a long-standing PCOS and a long-standing end ovulation. So thereby, if we carefully look into the stroma, it's going to be very dense. It's going to be ecogenic when you look on the transvaginal ultrasound. So the stromal ecogenicity are not a morphological variant of a normal ovary, but rather they're going to present as a functional entity, a silent form of PCOS for which the serum AMH could be the best marker. So stromal abundance, ecogenicity, you can identify even the milder forms, particularly about the ovarian stroma and the degree of vascularization that is required. The increased ovarian blood flow, if we put a colored Dopplers, why is it so? It's because of the increased expression of the VEGF, which is going to modulate the permeability of the theca cells and the IGF-1. So elevated LH levels will be responsible for increased stromal vascularization, thereby leading to new angiogenesis and, of course, a cytokine activation. So do measure the vascular blood flow in these patients, which is very, very important. And in obese patients, hyperinsulinemia may be proposed as a uniting factor with the increased vascular resistance, obesity, lipid abnormalities, and cardiovascular diseases. So why is the risk of OHSS seen? It's because of the reasons we just dealt with. So is it predictable? Yes, when you put your transvaginal and look into the stromal flow, look into the increased perfusion, because there is where the gonadotropins are going to reach more, and she may be at high risk, and you can regulate. So we've seen the reserve by the enteral follicles in the ovarian embolism. We've seen the response by this intra-ovarian flow. AMH, yes, we need to do because we know it's a recruitment regulator. It prevents all follicles depleting at once and increasing popularly an established method for assessment of any ovarian reserve. So we need to keep into the values of vision on TEM. If it's more than 3.5, yes, she may go into hyper response. And if we place the AMH values, we need to be careful with the labs. They're going to report us in picomoles per liter or nanograms per liter. And this conversion is given over here. And so thereby we find if she's a good responder or a hyper responder and regulate your FSH or the gonadotropin doses. So now we place this AFC and the AMH on our charts, and thereby we see over here what categories of the protocols that we could select. Normal, yes, a long-term regulation. If she's high, yes, we could go in for an antagonist and a controlled agonist trigger. So we need to go in for a patient-tailored stimulation. There is nothing as a standard patient for us. So we need to modify the stimulation protocols or go up somewhere like a step-up or a step-down protocols. And this was the conventional that we were using. And now we come to a low dose. We could start with a 75 milligram IO, and we monitor the duration C after 7 days. If there's no follicle, even you could increase by 100%. Yes, monoovulation in 69% of patients. Or you could go in for a chronic low dose where it's a really a hyper one, and you could start with around 37.5 or 50 and monitor her for the next 14 days and thereby increase the doses till she reaches the dominant. But yes, it's going to be a prolonged follicular phase, expensive with too many injections. So if you're somewhere with 112.5, this is a study where this is much, much better because it's going to lower the rate of complications and give you more monofollicular cycles too. So if you're going in for an IUS cycle, you could use this nomogram and place your AFC, place your weight, and just find out which dose is suitable for this patient. Step-down protocol, though it mimics the hormonal pattern in a natural cycle, yes, but not very much preferred. But if you're on an IUS cycle, you could start with 150 if she did not respond well in the previous cycle, and then the doses decrease to 112 or 75. Also, there could be a combination of using clomiphene with gonadotropin, but these days we are on to letrozole as a preferred drug. So we could combine letrozole with gonadotropin, where the number of FSH ampules would be less, the number of follicles was higher, but the pregnancy rates were yet similar. Combining either clomiphene with HMG or using letrozole with HMG, the study showed that yes, there were better pregnancy rates with letrozole HMG, maybe due to the anti-estrogenic effect with the estrogen, with the clomiphene, which was not there in cases with the letrozole. So a certain threshold of FSH is required, if you see over here, to initiate this follicular development. And once we are crossing this level, and it is maintained for a brief period, that's called as an FSH window. So the basic point here to remember is be careful of this FSH window. The more you're going to widen the FSH window, the higher is the response, the multiple follicles that you're going to get. So what we're going to do is we're going to reduce the dose. And if we don't want to hyper respond, we reduce this window. That's exposure time, and the total dose is a mild stimulation what we get. And when we are giving this mild stimulation, the FSH window concept with a mild intervention, stressing the significance of a limited duration of FSH elevation above the threshold rather than the height of elevation of FSH for a multiple dominant follicle selection. So this is that we are moving now towards a back to the future with less gonadotropin, which is going to be the best. So we've come from here with the conventional ovarian stimulation with the agonist triggers, with the agonist long protocol, to a milder ovarian stimulation with an antagonist. Our aim being avoid understimulation, avoid hyperstimulation, minimize cycle cancellation, and move to a zero OHSS. So we want to recruit a uniform cohort of the follicles. We want to prevent the premature LH surge, have 5 to 15 good follicles, avoid OHSS, minimal injections, good endometrium, adequate embryos for vitrification, and cost-effective and safe. But when we're going on to moving with the gonadotrophin, it's going to provoke a higher LH level. So we are likely anytime to get a premature luteinization also in those cycles. So we need to put in strategies to suppress this premature LH surge so that there are no cancels of the cycles, not lower number of oocytes also with us. So we have with the analogs as the agonist, which we find this is the normal physiology that we're going to get. And this is with the agonist where we get a slow fall into the level. And this is what is going to happen with the agonist. We get a sudden shutdown. So what were the advantages when we were using a long agonist protocol? It was very stable and a low LH and progesterone levels. So we were getting a good synchronized follicle development, a higher number of oocytes, and it was a short learning curve. But what were the disadvantages? There was an increased consumption of gonadotropins. We need to give higher dose, a prolonged treatment, typically estrogen withdrawal symptoms, sometimes patients. We get higher OHSS, too many injections, maybe the cycle cancellation, and cannot use an agonist trigger in an agonist long protocol. So we had the antagonist which acted by the competitive inhibition and thereby preventing the native GnRH from acting and a decline in the LH levels, and therefore a sudden shutdown of this the hormones that were troubling us. So there was a pituitary suppression and reduction in the severe OHSS and reduction even in the hospitalization maybe of these patients. So this agonist could be started after you started your stimulation on day 6 as a fixed protocol, or it can be done when the follicle reaches 14 millimeters and just continue till you get a mature follicle. So the GnRH agonists give maximum follicular recruitment, but the antagonists reduce the follicular recruitment. It was a shorter phase with an equivalent live births, fewer oocytes, and GnRH agonist trigger would avoid these patients into going into HSS. Now, this was the fixed or the flexible protocol that you start on 14 millimeter. When a comparison was done amongst the fixed and the flexible protocols, it was found that the fixed and the protocols can be both used, but it seemed that the flexible antagonist protocol in these patients would favor a better outcome in terms of the number of good oocytes and the embryos, especially in the anovulatory patients. So do the analogs have any impact on the oocyte and the embryo quality? When we look into this comparison study, it was found that the antagonists have got more oocytes with the cytoplasmic abnormalities, and they are much more pro-nuclear morphologies normal with the GnRH agonist. Long protocols, and of course the implantation rates almost on the par, and the clinical pregnancy rates but were better with the agonist protocols. So a fine tuning that we need with the antagonist cycle, yes, you could start it at 14 millimeters rather than a fixed one. There's no benefit in increasing the dose on the day you're going to start your antagonist. But take care that the time interval between the antagonist and the next antagonist injection should not be more than 30 hours. And the time between the last antagonist and the HCG should not exceed 30 hours. Posting is not much recommended because delaying the HCG becomes detrimental. But one thing that we often do is put these patients on OCP and then start the stimulations. So we need to take care because studies prove that if you put these patients on OCPs, the results are much less. You get a less better cohort. And even when you're giving an agonist and you put them on OCPs earlier, the same problem occurs again. Even with the flexible and fixed, if these patients are put on OCPs, you do not get a very good response. It's a slower follicular growth. It's a lower estradiol, it's a longer stimulation, and then higher FSH. So how can you achieve to get better with the antagonist? You do antagonist pre-treatment, no OCPs, fixed day start if they are ovulating. You do a flexible if they are anovulatory patients. You could even use medroxyprogesterone as 10 milligram from day 2 until the day of HCG. It's going to block the LH surge where you don't need injections, yes, but you cannot transfer in the same cycle because of altered receptivity. So to maximize the number of eggs and to prevent OHSS, you could give an agonist trigger, which could be safely given, but look at the surge that it's given. We need to note that this is a normal 14 hours period that we get over here, but the GNRH gives us a 4 and a 14 hours and just come back in 24 hours itself. So this is a very short luteal phase. We got an FSH surge, we're going to get more mature follicles, but look what has happened. Yes, the studies say the OHSS almost reduced to zero with the agonist trigger, but what has happened is there has been a detrimental luteal phase over here, a very short phase, and there's just a complete, this is with the HCG and this is with this, it's just a complete luteal lysis, which was not there when we were giving an HCG trigger, because this took care of the next 6 days of the luteal phase. We know LH is very, very important. So to secure this glut clinical after an agonist trigger, either we freeze all the embryos, or if you want to still carry on, you need to give a very good luteal support. You can add, there are studies with 1500 IU immediately after the oocyte retrieval, and then give estrogen progesterone support to these patients. If you look into the reproductive outcomes with agonist and agonist, the agonist trigger with the HCG, which was added 150 units after the oocyte retrieval, the results were much better than only with the agonist trigger. So this was a study which was done comparing, and yes, but we need to know, we've given 1500 IU, the studies on agonist trigger with 1500 claimed complete prevention of OHSS with excellent pregnancy rates, but the study confirms, yes, the risk is not still eliminated, and we need to be very careful. And these are the individualized luteal phase after GNRH by Himayuddin, which was given, but we can add these patients on metformin and cabergoline also. The dopamine agonist could be given for 8 days while you've done a pickup, and of course, it will take care of the VEGF and prevent them from going into any OHSS. Metformin reduces the intraovarian androgen by reducing hyperinsulinemia, and thereby it could be helpful if it put before into these patients on the PCOS. Yes, IVM could be an option to avoid them with the OHSS. If you go into the fresh and accumulative live births, the optimal number of oocytes were 13 to give a good pregnancy rate, no plateau, but the moderate increase after 27. But an oocyte yield beyond 27 is practically pointless. So segmentation of the IVF has revolutionized our perception concerning the stimulation and eliminated the OHSS. Cumulative live births is most meaningful outcome that we need, and we need the live births that we are craving for. So if in any doubt of these patients, you can go out for freeze-all of the embryos and electively cryopreserve could be transferred in an unstimulated, more physiological or a stimulated cycle. But for cryopreservation, the skill is the key, and embryo vitrification results better than costing. So proposed 3 steps would be the GNRH antagonist instead of a long protocol, the triggering the agonist used instead of HCG, and cryopreserve of all oocytes and embryos or blastocysts transferred in a TOG cycle. But yes, for this we need to care that a safe approach is required, extended culture to select embryos, but still blastocysts may be chromosomally abnormal, so time lapse to select the correct blastocysts. So when the world says give up, the hope still whispers, try still once more time. So recapitulate all your protocols, maybe you can get a better one. So choices are money, but individualization is the best selection. Thank you so much for a very patient hearing.
Thank you, Dr. Ritu. It was indeed a great talk. A small question to you. You said that batch IVF would be difficult for antac cycles. So, which cycle then would you suggest for for people who have started their IVF clinics anew and would like to resort only to batch IVF?
Yeah, so if they're going in for a batch IVF and they want to go on the antagonist cycle, they could be putting them on, instead of OCPs, if you want to just regulate them, you can give them estrogen also in the previous cycle for 10 days. Or you could, when you're starting, you could first 3 days give them an antagonist and then start your stimulation, which is going to keep those levels on a lower level, and then you could start your patients with. But the studies with OCPs are showing that, yes, the results are going to be, and we're just going to be struggling with a lower follicle and a poor output.
Okay. Thank you. Thank you. Any other questions from the audience session?
So no questions from the audience so far, but we would request the speaker to be around in case there are questions that are questioned.
Yeah, definitely, sir. Thank you so much.
Thank you. Thank you.
If we could move on to the next speaker, if Dr. Bharti Abdankar could please introduce Dr. Sanjeeva Reddy.
Okay. Uh, Thank you very much. First of all, thank you, Dr. Pratik sir. It's always nice to be a part of your webinar, because the way you conduct the webinar, the way you speak, and the way you conclude everything is really something I really appreciate it. So thank you very much for involving me in this webinar. The next talk is by Dr. Sanjeeva Reddy. We all know him. He is a professor and head of the Department of Reproductive Medicine and Surgery. He is the first department and university college to start first super specialty course in OBGY, MCH in reproductive medicine and surgery course in India. There are special awards to his credit. The main is Dr. B.C. Roy National Award in 2015 as an eminent medical teacher. It was by Medical Council of India, New Delhi. The Distinguished Faculty Award in 2020 by Department of OBGYN, Sir Ramachandra University, Chennai. He's an expert panel member. He's a specialist board member in reproductive medicine and expert member and assessor. He's a founder, secretary of Tamil Nadu and Pondicherry chapter of ISAR, past president of OBGY Society of Southern India in 2010, Chennai, organizing secretary of many conferences like AICOG, ISAR, and Yuva ISAR, I can say, in 2018. So with this, I will request Dr. Sanjeeva Reddy to talk on medical management of male infertility. Over to you, sir.
Thank you, madam, for your kind introduction. At the outset, I would like to thank President of AMOGS, Dr. Nandita Palsetkar, Secretary Dr. Arun Naik, and other committee members. My special thanks to Dr. Pratik, good friend of mine, for inviting me to be here to share some of my thoughts with you all. Today, I'm going to speak on medical management of male infertility. Infertility is a unique medical condition because it involves a couple rather than a single individual. It is defined as failure of couple to conceive up 12 months of regular intercourse without use of contraception in women less than 35 years of age, or after 6 months of regular intercourse without use of contraception in women 35 years and older. If you take the causes for infertility, the male factor contributes purely up to 20%, another 27% by combined factors, and 15% unexplained. That means almost 50% the male also is responsible. So if you want to investigate a couple, it is always advisable both you should take and examine instead of examining only and investigating only the female partner. If you want to classify, the simple way is just like this: pre-testicular, primary testicular, or post-testicular. If there is no cause is found, we'll call it as idiopathic. The other way also we can classify endocrine systemic disorders, genetic disorders of spermatogenesis, post-testicular, or idiopathic. You have to take detailed medical and reproductive history and thorough examination so that we can come to a diagnosis. So the simple test, what you have to do in the beginning is semen analysis. If it is normal, is all right, or you may have to go for higher like hormonal assessment, genetic studies, or subject the patient for immunological studies. So when you do the semen analysis, you may get two varieties. One, the semen report may be normal or it may be abnormal, like azoospermia, or abnormal like votes. So depending on that, we have to decide how to manage. There are three types of management is available depending upon the factor. Some of the factors, there is no treatment is available. In some factors, the treatment option is potentially useful. In other factors, there is no unproven or ineffective treatment that is called empirical therapy. So which are the causes? There is no treatment available, like genetic factors like Klinefelter syndrome, Y chromosome microdeletions, or developmental problems like Sertoli cell-only syndrome, or germ cell arrest, or primary spermatocyte. All these things, there is no treatment available. Suppose if you take, there is potentially useful treatments is available, like infection is there by giving antibiotics, sperm autoimmunity, sexual dysfunction, retrocode ejaculation. This all we can try some medical treatment. Varicocele and obstructive azoospermia, we can do surgical treatments. And sometimes there is no unproven or ineffective treatment that is called empirical therapy. Here there are so many drugs we will be using. Some are helpful. Definitely we cannot say this is going to be useful. So medical management, if you take, we'll discuss under this exam following headlines like idiopathic treatment, empiric treatment. They treat hormonal treatment for hypo, aromatase inhibitors and obesity-related male infertility. And there may be some specific treatment, there is any infection is there, or sometimes we'll be trying antioxidants for oxidative stress to alleviate these problems. When it's come to the empirical medical treatment of idiopathic oligospermia, there are many drugs we will be using. In general, this all not effective unless there is specific problem is there. See, this is the testosterone is the widely misused drug. If the patient we are investigating for infertility treatment, we should not give the testosterone at all because it decreases intratesticular testosterone, and many of the patients after receiving this continuous injection, they will come with azoospermia. So my request is, the patient is infertile, if you want to like that, don't use testosterone at all in this patient. Then what are the medicines and who benefit from medical treatment? So the hormones we have to do, the FSH, LH, testosterone, estradiol, these are the hormones essential if you want to treat any male patient for infertility. Here, depending upon these things, we'll have the diagnosis. So suppose the testosterone level is less than 300, then it is deficient testosterone levels. And FSH and LH, if it is less than 1.2 milliliter units, then it is called hypogonadotropic hypogonadism. It may be then estradiol. When you compare with the ratio between the testosterone and estradiol, usually it will be more than 10. If it is less than 10, it shows there is hyperactivity of the aromatase hormone, so that we will have problems, or pure hypogonadism or hypogonadotropic hypogonadism also. So this is the hypogonadotropic hypogonadism. This is the only condition is available for medical therapy. So this is the only specific medical therapy in male infertility is available. The hypogonadotropic hypogonadism may be congenital or acquired. Here the FSH level is less than 1.2 and testosterone also less than 300 nanograms per ml. The adult onset hypo, the specific medical therapy is giving urinary HCG or recombinant HCG. Here what we will be giving 1500 to 2000 IU of HCG weekly 2 to 3 times. We have to continue at least minimum 3 months. Then you check the semen analysis. If there is improvement, is there some sperm count, other things, you can continue the same. Suppose if there is no improvement, then you can add HMG 75 EU. This also along with HCG, you can give 2 to 3 times a week and continue for 3 months to 6 months. Sometimes it can take up to 1 year and 18 months also to get the sperms, but definitely you will get. Not only urinary, recombinant HCG also will work for the male hypo. They have studies showing there is increased testosterone levels, there is increased testicular volume, and also sperm counts. Next is, suppose the testosterone levels are lower, not only the FSH and LH will be normal, low, it can be normal or elevated, but if you compare with the ratio, testosterone to estrogen ratio, if it is less than 10, that suggests there is aromatase hyperactivity. How to manage this patient? This is particularly you can see in obese patients, there is most of the testosterone will be converted into estradiol. So here, if in obese patients, if there is testosterone estradiol ratio is less than 10, so their studies are showing in overweight patient, the incidence of oligospermia is very high. That is 1.2 times is more in overweight patients. In obese patient is more than 2 times the oligospermia rate is seen in these patients. How to treat these patients? So if it is less than that, you can go for the aromatase inhibitors like anastrozole 1 milligram per day. At least we have to try 2 to 3 months. By that time, it will correct the aromatase hyperactivity. Then the ratio will become more than 10, so that there will be improvement in the semen parameters. See here, the studies are showing there will be increase in the testosterone estradiol ratio, ejaculatory volume, and sperm count. So we can give not only anastrozole, we can give the letrozole also 2.5 milligrams instead of this one. In other condition, here the testosterone is low, FSH and LH will be normal, but estradiol ratio, testosterone to estradiol ratio more than 10, here it is pure hypogonadism. How to manage these patients? These patients will have severe oligospermia, and you can say like it is like one of the non-obstructive azoospermias. The options available here, you can try antiestrogens or HCG, either urinary or recombinant. How to go for here? Antiestrogens like clomiphene 25 milligrams daily for 25 days, give a gap of about 5 days. Some people will give continuously also. Some people will give 50 milligrams alternate day. Repeat the semen analysis after 3 months, but monitor the testosterone levels. It should be between 400 to 800 nanograms so that we can titrate the dose to maintain this level. And if in addition, if there is a testosterone estradiol ratio is less than 10, then you can add the anastrozole for this one, so that you can improve, you can expect the improvement. So whenever there is anti-estrogens are there, it will normalizes the testosterone levels if you give the HCG. Even in other conditions like Klinefelter syndrome, by giving this HCG for 2 to 3 months, when you go for the retrieval techniques by micro-TZ, the retrieval rate will be increased. Same way, in non-obstructive azoospermia also, if you try the HCG injections for these patients, this retrieval rate will be improved. Even in azoospermic patients also, if you continue for 2 to 3 months of HCG, the retrieval rate will be more. What are the key messages? Empirical medication for idiopathic oligospermia not recommended. Infertile males with hypogonadism, that is, the testosterone levels are less than 300. These are the candidates for treatment, they will improve. HCG is the treatment of choice for adult onset hypogonadotropic hypogonadism. And the aromatase inhibitors are helpful for overweight or obese men with aromatase hyperactivity, that is, the ratio is less than 10 with oligospermia. HCG and antiestrogens helpful to boost testosterone production in selected ART candidates. Minimum at least 8 weeks you have to give and monitor the testosterone levels in between 400 to 800 nanograms regularly and adjust the doses. And other treatment options is like specific treatment for whenever there is a infection is identified in axillary gland infections. So in 10 to 20% of infertile men, so you can find out the urethritis prostatitis, but only disadvantage is even if you suspect infection, if you send for culture, more than 80% of patients feel the cultures will come as negative. Then how to diagnose? In the semen analysis, if there is, whenever there is more than 1 million leukocytes per ml is seen, that is suggestive of reproductive tract infection. Here it affects the sperm quality. There will be increased DNA damage will be present in this patient, so that we have to treat this patient. What are the treatment options available? Antibiotics, anti-inflammatory, antihistamines, and antioxidants. There are some studies, they showed giving azithromycin 1 gram as single dose, advising the patient to ejaculate frequently once in 2 to 3 days. In addition, if you add antioxidant to this patient, the leukocytospermia will be decreased and the pregnancy rate will be increased. And also we can, in some patients, there will be increased oxidative stress. In 30 to 80% of infertile men have elevated markers of oxidative stress. This is an emerging explanation for several cases of male infertility. So these are generated from aerobic metabolism of sperm and leukocyte mitochondria. So sperm and seminal plasma itself contain antioxidants. There are two types. One is enzymatic, another one non-enzymatic. This enzymatic, it inactivates ROS by conversion into other substances. In non-enzymatic, it neutralizes the reactive oxygen species. Here, oral antioxidants classified according to their mechanism of action. It may be catalytic or scavenging effect. In catalytic antioxidant, it enhances the already present antioxidant enzymes. I told you it will be present in the semen itself. To already present antioxidant enzymes, it enhances the action. Whereas in scavenging, there are two types. It is water soluble or fat soluble. In water soluble, it reacts with the oxidants in the cytosol like vitamin C. In lipid soluble, it protects cell membrane from lipid peroxidation. That's why vitamin E will help. So the studies are showing there is, if you treat with antioxidants, there is increased pregnancy rate, live birth rate of 4.85 times. And also pregnancy rate, if you see, there is 4.18 times the increased pregnancy rate. And also the decrease in 13.8 times decrease in DNA fragmentation rate, but there is no effect on miscarriage, sperm count, and sperm motility, even if there is no change, but live birth and pregnancy rate will be improved in this to treat. There are various studies. It is giving different ways. Some studies are showing beneficial effect. Some they say there is no effect. And if you give longer time, higher doses, there may be detrimental effect. So it is suggested there is short-term use appears to be safe, but caution against indiscriminate use of high doses for longer periods of time. How to use antioxidant therapy? Focus on identifying and controlling source of increased ROS, like varicocele is there, treat it. Genital infection, correct that one by giving antibiotics. If the patient is smoking, ask them to stop. If they are taking any medications, ask them to stop. Stop the misuse of the drugs and systemic diseases and reduce the pollution. And if they are exposed to radiation, correct that one. Differentiate between sperm and leukocyte source of ROS is important. Testing for leukocyte in semen, that is important to diagnose. And select antioxidant formulations and doses. Instead of single thing, there are multiple antioxidants available. That's why if you take any other preparations, the pharmaceutical companies, there will be combined effect. Each is having different functions. That is what the evidence says. There are many papers. The effect of antioxidant supplement on sperm parameters in infertile male smokers. Here, they have taken a mixture of antioxidants in 50 infertile oligospermic and astenospermic men participated. They have given. After 3 months, they have seen there is increased sperm volume, increased motility, morphology, count, and progressive motility also improved. The conclusion of the study is consuming vitamin complements once a day along with 200 milligrams selenium every other day can effectively improve the qualitative parameters and quantitative parameters in infertile male smokers and also the pregnancy rate. There is a latest review in 2021, antioxidant-based therapies in male infertility. Do we have sufficient evidence? Here, they have selected 30 clinical studies. Of these, 1/3, they didn't mention any pregnancy rate or live birth rates. And 30 studies considered in this study review. In that, 43.3% were only case control studies, and 2/3 they have taken older patients above 40 years, and 40% of these studies showed only single antioxidant. Therefore, it appears that further studies are needed to clearly define the usefulness of antioxidant therapies to treat male infertility, because there is no uniformity in the studies. Sometimes they have taken only single drug, sometimes combined, and there is no uniformity in the age also. So that's why we are not able to say definitely whether it's going to helpful or not. Finally, the Cochrane review, this is a 2019. Here they have included 61 studies, more than 6,000 patients. They have taken the age group between 18 to 65, those who planned for ART, and they have combined 18 oral antigens in this. The evidence of low to very low quality. So the evidence is very low quality. The main limitation was that of the 44 included studies in the meta-analysis, only 12 studies reported on the live birth or clinical pregnancy. You can imagine. The evidence currently is, this review is up to, the evidence is up to, they have taken up to February 2018. The author's conclusion is, there is low quality evidence from 7 small randomized controlled trials suggesting that antioxidant supplementation in subfertile males may improve live birth rates for couples attending fertility clinics, but low quality evidence suggests that clinical pregnancy rate may also increase. Overall, there is no evidence of increased risk of miscarriage. However, antioxidants may give more mild gastrointestinal upset, but the evidence is of very low quality. Subfertile couples should be advised that overall, the current evidence is inconclusive based on serious risk of bias due to poor reporting of methods of randomization, failure to report on the clinical outcomes like live birth rate and clinical pregnancy rate, often unclear or even high attrition, and also imprecision due to low event rates and small overall sample size. Further, large, well-designed, randomized, placebo-controlled trials reporting on pregnancy and live births are still required to clarify the exact role of antioxidants. So, the key message is, in asymptomatic luteospermia is mainly caused by urethritis. ROS production increases with an increase in leukocyte numbers. Antibiotic therapy is suggested, but effect on fertility is still unclear. Oxidative stress impairs sperm function and is a risk factor for male infertility. Oral antioxidant supplementation for subfertile males improve the chance of live birth for couples undergoing ART. Well-designed studies are needed to determine the best candidates for oral antioxidant therapy and which formulation and dosage yields better results. So, in seminals, if you have things, depending upon the type of things, you can go for the specific medical therapy or empirical medical therapy, or like if there is infection, if you suspect, you can treat, or you can give empirically like antioxidants in some of the conditions like ROS or increased DFI, it can help. Thank you.
Thank you very much, sir. It was very informative. Your slides were very excellent and very expressive. One question I would like to ask is, like we treat ovulation induction CC, when it is failed, we start with letrozole. So also, should we do with male patients, we should start with clomiphene and do testosterone levels after 3 months. And if there are no results, should we go for letrozole? What you suggest?
No, madam. Letrozole, clomiphene is for a different purpose. Letrozole is a different purpose. Suppose their testosterone estradiol ratio is less than 10, then we will be giving the aromatase inhibitor, either anastrozole or letrozole. Suppose there only it's going to help. So first, this one, like clofazimide HCG, that is different group, that is going to improve the per count. If there is any aromatase inhibit, like activity is more, there only we are going for this anastrozole or letrozole.
Okay. And what about the combination of clomiphene and antioxidants?
That we can give, madam. So like even if the count, other things are not improving with the antioxidant, the quality of the sperm particularly, that will improve. And in the low doses we use for shorter time, it's not going to create any problems. We are not, definitely we cannot say it is going to improve. Whatever benefit is there, that you can get.
Thank you, sir.
That's what studies are showing. Like.
So, and with the obese patients, like, do you go in for higher doses of anastrozole or letrozole, sir? Obese men?
No, 1 milligram is enough, madam. That is for 2 to 3 months. Like letrozole also is 2.5 milligrams. After 3 months, suppose if the ratio is not corrected, then you can increase. Otherwise, not necessary. Most of the time, it will get corrected.
Right. And so, as you rightly said that I think we get cultures, we get almost all negative, and then we still have that. So I think we must go for treatment of every patient who has got increased leukocytes, because there when IVF fails, so many problems later on otherwise.
Yes, but many times it's not possible for us to get the positive report.
Yes.
That's why most of the time I will be giving like doxycycline for 2 weeks.
2 weeks.
So like that way it will be helping.
Thank you, sir.
Thank you, sir.
Thank you very much, Dr. Sanjeeva Reddy, sir, and Dr. Bharti Abdulkar, ma'am, for chairing that session. I would like to request Dr. Bharti Maheshwari, ma'am, please introduce our next speaker, the eminent legal consultant, Dr. MC Patel.
Good evening, everyone. And first of all, I would like to thank MOX and especially Dr. Pratik Tambe, sir, that who has invited me for this CME. And of course, in the leadership of MOX, Dr. Nandini and Dr. Nandita Pashikar and Dr. Others. And besides that, other speakers and greetings to all chairpersons. And this topic, what you have kept, Dr. Pratik, that is really very important. And not only knowing the skills of the infertility treatment, but most important part is documentation. And we all know that litigation related to ARTs, they are so much of common. And though we are fortunate that ICMR has already drafted so good document, but still we need to know that. And for that, none other than Dr. MC Patel. We all know that he needs actually no introduction, but I know him personally also as a great Foxy leader when I was doing MDP committee chairperson under his leadership. And we all know as President Foxy, medical legal consultant, as chairperson medical legal committee, as well as he is having the very administrative and academic post in the Ahmedabad Society. And now, without doing any delay, I am inviting to Dr. MC Patel for his talk. So now over to Dr. MC Patel, sir.
Thank you, Dr. Bharti, for a kind introduction. My slide is not moving.
So just click on the slide once and then use the keyboard arrow.
Yes. So, greetings from Statue of Unity, tallest statue of world, and we all are proud of that. Relevance of consent in ART or importance of consent in ART is the subject to decide. Warm welcome to all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank MOX Endocrinology Committee and Dr. Pratik Tambe in particular for inviting me to share my views about the subject. I always start my talk with this: is it worth discussing? Yes. Then why? Because medical legal litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first as far as these medical legal consequences are concerned. And as far as consent is concerned, this is very famous case Samira Kohli versus Dr. Prabha Manchanda, which was decided in 2008 in Supreme Court, and what could be the valid or ideal consent in Indian context was decided and discussed during this particular case. And the same Dr. Prabha Manchanda, our senior gynecologist from Delhi, just passed away last month only. So this lecture is to her in memory of Dr. Prabha Manchanda. Fact of that particular case was, it was diagnostic laparoscopy plan, consent was taken, and she was explained it is for admission and treatment for surgery, that was diagnostic laparoscopy. She was also explained that surgery to be minor. She was also explained that laparotomy may be required, but she was not explained about hysterectomy, and she was not explained about alternative modality of treatment. So when patient was under anesthesia, there was some bleeding problem and abdomen was to be opened and total abdominal hysterectomy was done. So imaging the situation, patient had been for diagnostic laparoscopy for primary infertility in future. She was going to get married in very recent future, but as she was 44, she was interested to have a workup. So she was subjected for diagnostic laparoscopy and total abdominal hysterectomy was done. Assistant took consent for hysterectomy from old mother who was waiting outside and hysterectomy was done. So allegation in this particular case was filed, notice was served, hysterectomy done without patient consent when patient was under anesthesia, no preoperative information about alternative modalities of treatment, and patient suffered for premature menopause were the allegation. So point in issue in that particular case was, can the doctor be held negligent for taking decision of total abdominal hysterectomy on table? No. So thanks goes to Dr. Sudha Salhan. She was invited in the court as an expert witness and she gave opinion that in that particular given situation, to save life of patient, it was very much needed to go for hysterectomy. So whatever Dr. Prabha Manchanda did, any prudent doctor would have done in this type of situation. But one more issue was there, that is doctor still liable? Court conveys that there was no negligence on part of doctor as far as hysterectomy is concerned. But still, is the doctor still liable? Yes. Then for what? Under section 351 of Indian Penal Code, and that is for assault and battery for doing total abdominal hysterectomy without consent. So hysterectomy was not an issue, but without consent, it was issue, and consent was for diagnostic laparoscopy only, the argument on part of patient and her advocate. Laparotomy may be needed was explained, but it implied conservative surgery and not total abdominal hysterectomy. So compensation worth rupees 25 lakhs was demanded. This case was instigated by her fiance, but court awarded compensation only rupees 25,000 plus bill if paid, which was not paid, plus rupees 5,000 against cost, and it was only for lack of consent. So with this case, what is the ideal consent? What is the valid consent in Indian context was decided during this particular case. So any consent to be valid, some criteria were decided during this case. First criteria is capacity or competence. Who can give consent? When patient is adult, when patient is mentally sound, only patient can give consent on her behalf. Nobody else can give consent on her behalf as far as her age and mental status is concerned. If patient is minor, if patient is mentally challenged, then consent of guardian is required. And if it is an emergency, then no consent is required. Consent should be voluntary. It should be free, signed by patients, and others are witnesses only. And it should be informed one. So, are your patients properly informed is the main criteria for any consent to be valid consent. So patients should have knowledge about nature of treatment. with its benefit and its side effect. No fraud, no coercion, no false promise as far as result is concerned. And at the same time, we have to offer all the available alternatives to the patient with success rate at your clinic, in your city, in your state, and in your country. So whenever you are offering any treatment related to ART, this is also very much required in eye of law. Refusal of treatment. Many times when you explain everything and patient is confused or frightened, patient may refuse to give consent for further treatment. So as far as informed consent is concerned, we should explain about if at all we are dealing with a high risk condition. Say for patient is having any comorbidity, hypertension, diabetes, and patient is going to be subjected for ART treatment, then we are under obligation to inform all this in advance. And course of event from times of admission. So many times at the time of admission, if we have explained everything in detail and if we have taken consent in a proper way, then it will not be difficult to face a case in court if at all it happens. So including all the probable risks. And if you are dealing with a very high risk patient, then risk including life should also be explained. Probability of shifting to ICUI, involvement of other doctors, CPR, CVP line, intubation, or any emergency measures. So we have to explain everything to the patient in this type of situation. And this is very much important. We have to explain about anesthesia, hemorrhage, blood accumulation, infection, injury to surrounding structure is also very much important, scar development in future, and addition or hernia formation in future. So there are certain rare conditions we have to very quickly explain about any allergy to a drug, or in future fistula formation or placenta previa, adrenal placenta, burst abdomen, incontinence of or retention of urine or so. So, and at the same time, possibility of blood transfusion should also be explained to the patient. And at the same time, we have to explain about anesthesia also, because certain procedures we have to go under anesthesia. So we have to explain about this also, that is nature of anesthesia, benefit of anesthesia, purpose, effects, alternative, and substantial risk. So, and there should be separate consent for anesthesia and your procedure. Then there cannot be blanket consent. If at all you feel that blood transfusion may be required, then for that also separate consent is required. And before you go for consent for blood transfusion, purpose, effect, alternatives, substantial risk involved, and alternatives related to blood transfusion should also be explained. So in this particular case, this was also asked, then should we explain all possible complications? So not to anticipate certain complications or requirement depending upon the condition of the patient, and no need to explain remote or theoretical risk involved, which may frighten or confuse the patient and result in refusal of consent for necessary treatment. But at the same time, if patient refuses to give consent, then need to explain risk of refusal of treatment, and at the same time, no need to explain remote or theoretical risk of refusal of treatment, which may persuade the patient to undergo a fanciful or unnecessary treatment. So balance should be achieved as far as consent is concerned. One more thing, sorry. Only 1 minute, there is some problem.
Sir, you can continue without the slides.
No.
Fine, sir.
There was some technical problem, and
Yes.
it will not take much time. Only
No.
1 minute. Only 1 minute. So we were here. One more question: should consent be written always? So there are only 3 conditions in which consent should be very much written. So these are the 3 conditions: organ transplantation, PCPNDT Act for sonography of antenatal patient, and case of MTB. So in any other cases, one can go for oral consent also, but it is very difficult to prove in court of law that you had counseled patient well and you had taken valid consent. So though it is not mandatory, but it is always advisable to go for written consent, because burden of proof is always on our shoulder to prove. So it is always better to go for written consent. Consent can be taken by assistant doctor also. So not necessary that person who is going to perform procedure or any surgery should take consent. Consent can be taken by assistant doctor also. But in that particular consent form, that assistant doctor will have to sign, because in one of the cases, that is C. Jaipal Reddy versus Dr. Padmini Velluri, National Commission has mentioned that consent is not mere piece of paper where patient or relative should sign, but it is a document of your communication with the patient. Whatever you have counseled, whatever you have explained to the patient about your treatment modalities or any procedure or surgery, so it should be well explained, and it should be enter all these important things in consent form, and then it should be signed by patient, one of the witness on part of patient, signed by doctor, and one witness on part of doctor. Then only it becomes a valid consent in eye of law. Consent in era of COVID-19, we know possibility of spread from patient to others, possibility of spread from others to patient. It should be explained before going to go for any procedure with all these precautionary measures. And as far as history is concerned, any history of travel abroad or interstate, any history of contact with COVID patient or suspected COVID patient, or any history of quarantine, either home or hospital, should also be explained. And if at all, if she is positive, then please inform appropriate authority as per government notification. And if your hospital is certified to go for treatment with COVID positive patient, then you can, otherwise you will have to refer patient to another center. So with this background of consent, let us see how this is relevant in our ART practice. So rightly mentioned by Dr. Bharti also, ICMR has given a prescribed form under Rule 15, Sub-Rule 1, as far as ART treatments are concerned. Say, for example, Form D, that is for IVF and ICSI. And in all these forms, the 3 things are very common. It should be signed by couple. Whenever you offer ART treatment to a couple, it should be signed by both partner, and consent should be endorsed by ART clinic, and this consent holds good for all the cycles performed at the clinic. So if you take consent for one time, then all the cycle related to that particular treatment, it is sufficient, and not to go for consent every time. And at the same time, this is also very much important before you go for any kind of procedure, and patient should be well aware, or patient should be explained that there is no guarantee. There is no guarantee about oocyte formation, oocyte retrieval, fertilization, implantation, or carry home normal healthy baby. So because when we discuss the basic principle of consent related to that Samira Kohli Prabha Manchanda case, in that case also court has very specifically insisted that patients should have knowledge about everything, and you cannot give 100% guarantee for anything. So patients should have knowledge that in this type of procedure, how much the success rate is there. Let us see one more form, that is form E, and it is form for artificial insemination with husband or intrauterine insemination with husband. So again, all these points are common in all the consent. But again, here also, no guarantee for fertilization, implantation, carry on, normal healthy baby. But this should also be explained that outcome may not be the same as per normal pregnancy. So even with treatment with ART, there are also possibilities of abortion, multiple pregnancy, fetal anomaly, complication related to pregnancy and labor. So it is just like normal delivery or a normal pregnancy, one may go for these complications also. This is very vital area, and that is form F, artificial insemination with donor or IUI with donor. So in this also, again, it should be signed by couple, but special declaration on part of husband is very much required in this. So as husband declares that as a result of insemination, children shall be as my own and shall be my legal heirs. So there should not be any social problem in future. So the first consent, that husband should give consent to go for artificial insemination with donor, and at the same time he should take a declaration that child or children born with this treatment will be my legal heirs in eye of law. And both declare, patient as well as her husband, no attempt to find out the identity of donor. They will not try to find out identity of donor. This is also very important point to be taken as the part of counseling and at the time of taking consent. One more form is, that is form G, and it is for freezing of embryo. So in this also, common points just I have mentioned, but as far as this specific freezing of embryo is concerned, then patient should take undertaking. So patient will give undertaking like this, that we understand it is for 5 years. For extension, request prior 6 months. If more than 5 years it is to be preserved, then again a patient or a husband may put request. If there is no communication from our side, clinic is free to use them for research purposes or dispose of them permanently. Some of the embryos may not survive the subsequent thaw, and frozen embryo replace cycle have lower pregnancy rate than that of fresh embryo. So we should explain everything related to this freezing of embryo and its limitations. But one more important area, in event of unforeseen death, because when embryo is freeze, and say for example, one of the partner is expired, then whom this freeze embryo can be given for further treatment or so. So there should be very clear during taking consent in this type of situation, that in this type of situation, when one of the partner expired, then should it be given to a partner who is survived, or should it be allowed to get perish? So it should be very clear. And one more condition, in event of death of both, then what should be done with this free embryo? So all these things should be very clear before taking consent in this type of situation. So in event of unforeseen death, either to perish, to be handed over to my wife or my husband or commissioning partner. Because if it is a case of surrogacy, say for example, and freezing embryo is done, and one of the commissioning partner is expired, then could it be given to another partner? If consent is given specifically for that, then only you can hand it over to partner who is survived. So it is very clear that we should be very clear in this type of explanation before taking consent in this type of situation. And If they have given consent, then in event of this type of unforeseen death, we can give this embryo for research purposes also to any clinic who is authorized by government. One more form, and that is form H, and this is for surgical extraction of sperm. So again, all these parameters are same, but this is the area we have to explain specifically. If sperm retrieval fails, options available for retrieved oocytes are insemination of all or some oocytes using donor sperm, donation of oocyte to another infertile couple, or disposal of oocyte according to ethical guidelines. So in this type of situation, that is surgical extraction of sperm, we should explain this to the couple. One more important form, that is form I, and this is for oocyte retrieval or embryo transfer. So again, we have to explain this, that explain and give consent for oocyte formation by hormones and other drugs, side effects of drugs, oocyte retrieval under ultrasound guidance or laparoscopy, mixing using IVF or ICSI technology, as per the case may be. It could be of my oocyte with sperm of my husband or anonymous donor oocytes with sperm of my husband or anonymous donor. Whichever the case may be, we should explain everything in detail to the couple. And again, this should also be explained that no guarantee of carry home normal, healthy baby. So as far as this oocyte retrieval and embryo transfer part is concerned, same is to be explained again, but specifically explain and give consent for transfer in my uterus of oocytes mixed with sperm, resulting embryos, our cryopreserved embryos, embryo or embryos of anonymous donor, and resulting embryo number 1, 2, 3, whichever embryo you are going to transfer into name. If it is a case of surrogacy, then here we have to write name of that surrogate patient. So this should be explained in this type of situation. And again, this should also be explained that we will be legal parents of child, and the child will have the legal rights on me in case of donor. If you have used donor sperm or donor ovum, then this is an important point to be kept in mind. As far as form J is concerned, it is for agreement for surrogacy. Here it should be signed by both couple, commissioning a couple as well as surrogate patient and her husband. And both of our husband should have given that we have given our free consent to go for this type of treatment. And again, this should also be endorsed by ART clinic. There are many points to be discussed as far as surrogacy part is concerned, but today is not my subject because it needs a separate lecture. As far as form K is concerned, it is for donor of oocyte. So here there are certain points to be kept in mind. All these points are common, but specific points explain no direct or indirect contact between me and recipient. So if it is a case of donor of oocyte, then on part of oocyte donor, there should be consent. There no direct or indirect contact between donor and recipient. And same way, consent should be taken from recipient also. They will also not try to know identity of donor also. My identity will not be disclosed to recipient or child born through the use of my gamete. So this is for donor. No legal rights whatsoever on resulting offspring and vice versa. So donor will not claim any right on that child or any property that child possesses in future, and vice versa. Child also can have no right to go for right for any property of donor. So this should be explained well in advance, and consent should be taken. And one more thing, stimulation of my ovaries for multiple follicular development should also be explained to the donor before you enter into the contract. With all its side effects of all drugs or hormones treatment we use, recovery of one or more eggs under ultrasound guidance or laparoscopy under sedation or anesthesia, fertilization with sperm of recipient's husband or donor, whichever the case may be, and transferring resulting embryos into recipient. So it should be well explained to the donor of oocyte. And again, if applicable, my husband has agreed to the donation of my oocyte. So if patient is married, then consent of husband is very much required to go for donor oocyte also. So it should be specific. One more form is, that is form L, and this is for donor of sperm. So all other criteria will be the same as per donor of oocyte. So again, in this also, it is explained, no direct or indirect contact between me and recipient. My identity will not be disclosed to recipient or child born through the use of my gamete, and no legal rights whatsoever on resulting offspring or vice versa. And again, in this also, if he is married, then consent of her wife. My wife has agreed to the donation of my sperm. So this should also be the consent, a part of consent. And apart from this prescribed form, there are certain points which should be kept in mind, and there one separate consent should be taken in other form with all this point. We had been explained and we understood about method of treatment, probable complications including OHHS, treatment of complication or complications, possibility of success and failure, probable expense, custody of children if born with anomalies. Because with this treatment, if in spite of all our care and caution and precaution, if child born with some anomaly, then commissioning couple or patient taking treatment cannot say no. And if it happens, then it invites legal implications also. So this should be explained prior, and consent for the same should be taken. Custody of child or children in event of death of couple, just I mentioned prior also. So it should also be clarified in advance. So whether this child should be given to their grandparents or any other relative, or they should be given to orphan house or so. So this should be clear before taking consent in this type of situation. So to conclude, carry home message is, take valid consent. Valid consent, just I mentioned, is not mere piece of paper where a patient or relative signs, but it should be very specifically mentioned in that consent paper about all your conversation with the patient and signed by patient and husband. Consent is must for any type of treatment or medical procedure, and it should be written and informed. Blanket consent has no value because it has no legal value, and consent provides us a legal protection in cases of legal consequences. So with regards, and this is very small clippings, even if you want to help anybody, then also consent should be taken. This gentleman, after jogging, relaxing, taking support of his car, and this person driving a car, he thinks that he is in need of some help, and he is going to help him, and see how he helps. So even if you want to help somebody, then also consent should be taken. So salute to all the organizers and Dr. Pratik Tambe in particular for inviting me to share my views about the subject. Thank you very much. Please do not assume. Please ask if any question or query if time and chairperson permits. Thank you very much.
Thank you, Patel sir. Excellent talk as usual, and excellent topic selection as usual by Dr. Priti. We enjoyed all talks. Very nice talk by Dr. Ritu and Dr. Reddy also. So now over to Dr. Priti.
So thank you very much, all the respected chairpersons and the eminent speakers. We have about 3 or 4 questions which have come in from the audience. We have nearly 600 viewers who are logged in to today's event. The first question is from Dr. Rashmi Vora. She's from Chennai, First Adjustment, Tamil Nadu. And her question is for Dr. Ritu Khanna. She's asking, what is the role of aspirin in preventing OHSS in PCOS women?
There are a few studies when you could give aspirin, but routinely, I think we are not giving to a patient unless this PCOS has been a recurrent implantation failure.
So there is limited evidence to suggest that aspirin may be beneficial in improving maybe pregnancy rates and implantation rates. And sometimes many ART consultants blanket start aspirin at the beginning of every cycle. So specifically regarding preventing OHSS, there may be some limited evidence. The next question is from Dr. Harsh. He is also from Chennai, and his question is for Dr. Sanjeeva Reddy. First, he congratulates sir for an excellent presentation, and then he asks, how long can the hormonal therapy be continued in hypo males where fertility is not a concern and the treatment is just for the symptoms?
See, fertility is not a concern like that. No need for us to continue the hormonal treatment. Only for testosterone deficiency alone, for that we can take care. Otherwise, for fertility purpose only, we'll be continuing for sperm production, other things.
Thank you, sir. Thank you very much. There is one question which is coming from Dr. Neha, and that is for our final speaker of the day, Dr. MC Patel, sir. And she is asking, sir, how long do we as an ART clinic need to preserve consent forms and records? Does it need to be physically preserved? Does it need to be in electronic form? What does the law say?
So you can preserve record in any form, either physical or on electronic media or so. And it should be preserved for 10 years. And after 10 years, you cannot dispose it off. It should be transferred to National Registry. And in any situation, if at all clinics is closed, then all the records should be transferred before that to National Registry. But again, there is some gray area because National Registry is still not officially formed, because this bill is passed in Lok Sabha, yet it is to be passed in Rajya Sabha, and then it will become Act. But in that particular Act, it is very specifically mentioned that after expiry of this 10 years, all the records should be transferred to National Registry.
Sir, in the old days, we used to say that in Western civilization, the child that is born of fertility treatments has the legal right to know who are their biological parents once that child becomes a major, whether it's age of 18 or age of 21 as defined by the country. What does the law say in India? Such a child, will they have such rights?
No. As such, there is no this type of right to know identity of donor. But if in a very tricky situation for treatment of child, if medically, if it is required to know the identity of donor, then court may permit to disclose the identity for certain test with that donor related to treatment required to that child. But for that also permission of court will be required. So
and then we will be legally bound to preserve such records until that child becomes 18 or 21 years.
So all these records are with National Registry. So if at all it is required, then it will be retrieved from National Registry. Otherwise, in other cases, not related to ART, usually in our lecture of record, we always say, as far as our obstetric part is concerned, child may shew at any time after attaining majority within 2 years of period. So all the record related to delivery, we should preserve at least for 20 or 21 years.
and then we will need to have a separate go down or storage just for keeping
but in era of this electronic media, I mean this computer, etc., we can preserve in this, and for that also certain firms are there. They give their services. If you give all the physical record, they will convert it into digital form, and it will be given to hospital. So it is
we
now
will have to keep
available.
it in the cloud storage, just like Google and Amazon.
Yes, yes.
That revolution is also coming very soon
Yes.
to India. There's one final question, and this is from Dr. Priyanka, and she is asking regarding the role of the newer antioxidant molecules which the companies come and try and talk about. So I have a few slides regarding that. So with your permission, I will just share. And specifically, her question is regarding coenzyme Q10 and astaxanthin. These are two of the most commonly used antioxidants. So as we know, the mitochondria is the seat of energy for the sperm. And probably this ubiquinone or coenzyme Q10 is one of the important molecules as far as mitochondrial ATP production is concerned. There are some limited studies which have been conducted all over the world, including from India. This is one such study from Lucknow in India regarding the forms and the effect of coenzyme Q10. And they go on to show that sperm density improves significantly, motility also improves, but the numbers that have been quoted in this study are quite small. In fact, the number of patients is hardly about 50 or 60. Similarly, there are other studies also, and meta-analysis from these limited studies have shown that there is significant improvement in the sperm parameters. Whether this translates into better pregnancies, more number of pregnancies, take-home babies, again, that's something which will require further research, as Dr. Sanjeeva Reddy has rightly pointed out. The parameters which are seen are the sperm count, motility, and the rapid progressive motility, all of which have shown improvement. So this is one of the molecules which has shown promise. We also have other molecules like astaxanthin, which is a very powerful antioxidant. In fact, one of the most important antioxidants which are known to man. It's almost 6,000 times more potent than vitamin C and E, which we call the poor man's antioxidant. The dosage is about 8 or 16 milligrams per day. And when you give it for a period of about 3 months, there is significant improvement in the sperm parameters. There is significant improvement in the pregnancy rates as well. But then, as we have seen here, this particular study shows 44% increase in the pregnancy rate. But as Dr. Sanjeeva Reddy has said rightly, that even meta-analysis shows that the volume of patients in these studies is a little low. We need to actually use these particular agents in our clinical practice. We need to be able to publish such evidence before we can actually give a wider recommendation whether these are going to be useful or not. I see Dr. Sujata Devi ma'am is held up and she has sent her apologies. So we just place them in record. Any closing remarks from all the chairpersons and the speakers before we wind up and we call it a day? Dr. Ritu Khanna ma'am, any comments?
I think pre-workup before an IUI and IVF is very important, and that's the key. If you do your workup better, I think you drive on a safe road.
Thank you, ma'am. Thank you so much. Dr. Sanjeeva Reddy, sir?
No, my request to all gynecologists, whoever is treating male infertility. So yesterday also I was seeing one patient. He had a nice sperm count previously 2 times. Yesterday one gynecologist referred to me with azoospermia. When I went to the history, he has received 12 injections of testosterone. That is the culprit. Like, please don't give any testosterone injections for male infertility. That is my request. If somebody listens like that, this today's webinar purpose is served.
Thank you so much. I think there's a clear message from Dr. Sanjeeva Reddy, sir, that if you give exogenous testosterone, it is going to suppress the body's own natural testosterone. And any benefit is going to be very short-lived. In the long term, it is going to cause significant harm to your patient. So please refrain from administering testosterone. Dr. MC Patel, sir, any closing remarks, sir?
As far as consent is concerned, it is very important document in your favor as far as any legal consequences are concerned. And it should be procedure specific. Whatever procedure you are going to go for, it should be related to that, and it should be explained in a very simple language which patient can understand, and then it should be signed by patient. And just I mentioned in my talk also, if patient is adult, if patient is mentally sound, then only and only patient can give consent. So few of our friends have a habit to take a signature of husband or so, and signature of patient is not taken. So it is not good practice, because it may invite you trouble legally in future at any time. So always take consent of a patient. And just I mentioned that in case of AID or IUI donor or in surrogacy, then all the party involved should sign the document. And it should also be explained not to have any social problem also, because in AID or IUI with donor, many times if this is not clarified before and proper consent is not taken, then it may invite some problem. So we should be very careful in dealing with this type of cases.
Thank you, sir. So very clear message from Dr. MC Patel, sir, to have clear documentation before performing any procedure, and especially so in ART, because this is something which is an emerging field.
Yes.
The laws keep changing, the GR keeps changing. Suddenly overnight tomorrow, there may be a new ART bill which is passed, which is still in process since so many years. So we have to be very up to date and ensure that our documentation is thorough and such records are preserved for a considerable length of time. I would like to close by offering my gratitude to our AMOG's President, Dr. Nandita Palshetkar, Secretary, Dr. Arun Nayak, to the four fantastic chairpersons today, Dr. Kiran Puttapoti, Dr. Bharti Abhyankar, Dr. Bharti Maheshwari. Dr. Sujata Davi was unfortunately ended up with a patient and she sends her apologies. With the ICOG chairperson, Dr. Uday Thanawala, the Secretary of ICOG, Dr. Ashok Kumar, thank you for the ICOG credit points. Three amazing orators, Dr. Ritu Khanna, Chairperson for the Foxy Food, Drug and Medico-Surgical Equipment Committee. Thank you for your wonderful talk on safe practices in ovarian stimulation. Dr. Sanjeeva Reddy gave us a very brief and crash course in medical management of male fertility. Thank you so much, sir, for gracing the occasion. And finally, last but not least, Dr. MC Patel, hats off to you, sir, for very precisely communicating how important consent is specifically in ART practice. We wish all of you a very fantastic day ahead, and we wish you all the very best in your future careers in whichever organization you choose to serve. I would like to finally conclude by placing on record my gratitude to our academic partners for today, Acumentis Viviana team and the entire Science Integra team. Subbu, Session, Rimon, all of you do fantastic work. 600 plus viewers logged into today's event. We wish you all the very best. Look forward to seeing you at our next event. Until then, goodbye. God bless. Thank you. Bye for now.
Thank you. Thank you.
Thank you, Dr.
Thank you, sir. Thank you so much.
Thank you very much.
And Dr. Sanjeeva Reddy.
Yes.
Thank you.
Thank you.
Thank you so much.
Thank you.
Okay.